For our psychiatric case, using our mnemonic OLD cards, we'll note the onset, or when did it start. For the duration, we like to ask our patient if they're constantly feeling depressed, manic, psychotic, or anxious. For example, in depression, are you depressed constantly, or are there periods where you're feeling good, or even perhaps manic, as we'll see below in bipolar or schizoaffective disorder? For psychosis, are you constantly seeing the writing or hearing the voices? And for anxiety, are you constantly anxious, or is this more in social settings? If it is intermittent, we'd like to note the frequency. How long does an episode of depression, mania, psychosis, or anxiety last for? And how many episodes have you been having per day or per week? Next, we can note the progression. Are the episodes appearing more frequently or more severely? Or if there has been no progression, we'll also be sure to state that in our patient note to show that we asked. To characterize an episode of depression, we'll use our mnemonic SIGI caps, as we'll see below. Mania, dig fast. Psychosis, it's important we clarify if it's auditory or visual hallucinations, and very high yield, as we'll see below, to ask about the content. And for anxiety, the mnemonic panics, aggravating and alleviating factors, treatments tried, and severity. Is it impairing your functioning? And also very high yield for any psychiatric case, we could help let the S stand for suicide as well. Are you having thoughts of harming yourself or others? For all cases, we'll order a mental status exam, CBC, serum electrolytes, TSH-T4, and a urine toxicology. In a normal bereavement, we'll have a recent family death, and we can also help use our SIGI caps to ask about sleep changes, decreased interest, feelings of guilt, energy or fatigue, low concentration, appetite or weight changes, psychomotor agitation, and suicide ideation. In hypothyroidism, we'll see fatigue or depressed mood, weight gain, cold intolerance, and constipation. In hyperthyroidism, interestingly in a form called apathetic thyrotoxicosis, seen commonly in the elderly, we could also see this apathy or fatigue or depressed mood. Hyperthyroidism could also present with hallucinations, and along with that, we could see a weight loss, heat intolerance, palpitations, and diarrhea. In drug-induced mania or drug-induced psychosis, we'll either see mania, and that can be seen with cocaine, inhalants, or marijuana, or psychosis, seen with phenylephrine, amphetamines, meth or ecstasy, benzodiazepines, or even an alcohol withdrawal, cocaine, LSD, marijuana, PCP, or steroids. And we can note a positive myalgias in our review of symptoms, hypertension in our vital signs, and our patient will tell us about their drug use in the history. And we'll add to our workup a CBK and myoglobin. In major depressive disorder, we'll use our SIGI caps for decreased sleep, decreased interest, feelings of guilt or being punished, low energy or fatigued, concentration. In a typical depressive episode, we'll have a decreased appetite and decreased weight, or in an atypical episode, we'll have an increased appetite and increased weight, psychomotor agitation, restlessness or feeling restfulness, and suicide ideation. The duration is typically greater than 2 weeks, and we need generally 5 out of 9 criteria. SIGI caps are only 8 criteria, the 9th being a depressed mood. Very interestingly, and also high yield, our patient does not need to actually report a depressed mood, as a history of a decreased interest alone fulfills the criteria. We either need a decreased interest or decreased mood, and we'll add to our workup a PHQ-9 and a Beck depression inventory. In mania, using dig fast, we'll see a distractible patient be irresponsible, grandiose, with a flight of ideas, agitated, decreased sleep, and very talkative. In bipolar 1, we'll have at least one manic episode. That's dig fast for greater than a week with functional impairment. And in bipolar 2, we'll have a hypomania episode. Dig fast for 4 days, but there's no functional impairment. We'll also have an episode of major depressive disorder, so we could also ask about the SIGI CAPS criteria. And we'll add here to our workup a mood disorder questionnaire. In psychosis, we'll have positive symptoms. Those include hallucinations, and it's very high yield. We ask about the content for our patient note, delusions, and disorganized speech or behavior. We could also have negative symptoms, including decreased interest and social withdrawal. In brief psychotic disorder, these symptoms will be going on for typically less than 1 month. In schizophreniform, for 1 to 6 months. In schizophrenia, for greater than 6 months. And in schizoaffective disorder, we'll have schizophrenia symptoms, mood-free for greater than 2 weeks, and the affective part will have a mood disorder, either major depressive disorder, and we'll use our mnemonic SIGI caps, or mania, and we'll use our mnemonic dig fast. In anxiety, we'll have an increased fear or worry, and in social phobia, it will be on performance and result in social avoidance. In anxiety disorder, these symptoms will be less than 6 months, and in generalized anxiety disorder and its proper form to include the full name of our differentials, it will be for greater than 6 months. In a panic disorder and for all anxiety cases, we also want to use our mnemonic panics for palpitations, abdominal distress, nausea, intense fear, chest pain, and sweating. And we'll add here a GAD-7. On the postpartum side, we could have postpartum blues, and that's sadness or anxiety occurring within 14 days since the pregnancy. In postpartum depression, we can make use of our mnemonic SIGI caps, as we see below, and we'll add as well a PHQ-9 and a Beck depression inventory. And finally, in postpartum psychosis, we'll have hallucinations, including a command to harm the baby or delusions, that thoughts that the baby is evil. We could also have insomnia.
So I'm going to show you how to deal with a psychotic patient or a manic patient, someone who is probably pacing up and down the room by the time you get in. Okay, so I'm going to knock and come in. Mr. Heskowitz? Oh, Mr. Heskowitz, my name is Dr. Ibe. I see that you're moving around. You're probably in some distress, okay? So, you know what? I'm just going to go real quick and try my best to help you, okay? I'm here for you and I'm here to help you. So please, can you take a seat for me? I'll be done with this as soon as I can, okay? And help you, all right? Okay, is it okay if I sit down? Okay. And that is how you deal with a patient who is psychotic or manic and pacing around the room. You want to make sure you let them know you're here for them and you're here to help them. And then they'll work with you. Thank you.
We'll start our neuro exam with hand sanitizer, and we want to ask our SP if we have permission to examine them.
Yeah.
Okay, and we're going to start with a hint exam, and we're going to use it as a guide to help us out. So for the head, we could comment that it's normocephalic, atraumatic. We'll move on to the oral pharynx. So we'll use a tongue depressor here. The key thing to do is you don't want to add too much pressure. For the SP, so just very lightly, you can press down, ask them to please stick out your tongue. Okay, and we'll comment that we don't see any lesions. We'll examine his thyroid, and so another good tip is to offer a glass of water. Would you like a glass of water? No. Okay, and now we could look to see if there's any visible lesions to the thyroid, and we don't see that, so we could ask him to swallow, and we could do one side at a time. Okay, now please swallow again. Okay, we didn't feel any palpable thyroid nodules. Transition to the cranial nerve exam. For cranial nerves, 1, we don't really assess cranial nerves, so we could kind of use that as a hint or as a placeholder to test their alertness and their awareness. So we could ask them, what is their name?
Kelechi.
And where are we right now?
The clinic.
Okay, good. And what time of day is it right now?
Afternoon.
Good. So now we could verbalize that they were alert and oriented times 3. Okay, now we could transition to the rest of the cranial nerve. So for cranial nerve 2, ask them to look straight ahead, and we're just going to check their pupillary constrict the response, and then we're going to do the same thing on the other side. We're going to do the same thing here, and then we're going to do it on the other side. Good. Now we could verbalize that they were pearl, the pupils were equal and reactive. We're going to transition to cranial nerve 3, 4, and 6. So please, you'll instruct them to please follow your fingers with their eyes, keeping their head straight, and you can see that he's able to follow. Okay. Trigeminal nerve, cranial nerve 5, and we're going to assess this with sensation. So please close your eyes and let me know if this is equal.
Mm-hmm. Mm-hmm. Mm-hmm.
Okay, good. So for cranial nerve 7, we're going to go ahead and ask him to please smile, puff out your cheeks. Okay, don't let me pop them. Close your eyes real tight, don't let me open. Cranial nerve 8, and we'll ask him to please close your eyes and let us know what side you hear this.
Left.
Okay, you hear this louder on your left?
Yeah.
Okay, good. So that would be a concern now if he has hearing loss on his right hand side. So continue with cranial nerves 9 and 10, so you could ask him to say, ah, please. And we would try to stick out your tongue, and we would visualize that we could see a non-deviated uvula. And while he's out here, we could also ask him to move his tongue left to right, and we could say that his hypoglossal nerve, cranial nerve 12, is intact. And now we will finish up with the cranial nerve 11, so please shrug your shoulders. Okay, so they are equal. And look that way and resist me. Okay. and look this way and resist my movement. Good. And now we're going to continue with MSRP. So for motor strength, please make a muscle for me. Okay, and resist me. So 5 out of 5, forward flexion, and extend 5 out of 5 on extension. Great. Now we're going to do sensation to light touch. So please close your eyes and let me know if you feel this equally on both sides.
Yes, I do.
Okay. Now we're going to do a pinprick. So please let me know if you feel this on your left.
Oh, yeah, I feel it.
Okay. Now we're going to do the same thing on your right. His reflexes. So we're going to look at his biceps reflex. We'll place our thumb on his biceps tendon. And this would, his normal reflex would produce a 2+ response, okay? And if we were concerned for a case of B12 or hyperreflexia, he would have a 3+ response. Okay, you would see that. Now we could assess his radial pulses as well. So we could do 1 at a time, 2 at a time if you're more comfortable, and we'll verbalize that it's a 2+ pulse, regular rate and rhythm. After we completed the MSRP for his upper extremity, we can now move down to his lower extremity, and we could do the same thing. For motor strength on the lower extremities, could you please kick out? Okay, good. So that's 5 out of 5. Now could you please kick in? Good, 5 out of 5. Now we'll go into sensation. So please close your eyes and let me know if you feel this equally on both sides.
Yes, I do.
Okay, great. And now we're going to go into pinprick. So this is a pinprick. I'm going to start on your left side, and please let me know if you feel this all the way down.
Yes, I feel it.
Okay. And now I'm going to go onto your right side, so please let me know if you feel this.
Yes, I do.
We could instruct him to relax, and we'll do a patellar reflex. So a normal patellar reflex would be like 2+, and then if we were concerned like hyperreflexia or B12, we would get a hyperreflexic response. So just relax, and you would see something like this. And we can continue to demonstrate with the tap on his Achilles tendon. So we'd start right here, and we would get a normal reflex, and if this was a case of B12 and we were concerned about hyperreflexia, he would give us a dramatic response. Okay, you feel that. We could also test while we're down here a Babinski, so we could start on the bottom of the sole and go into the big toe. And note, if he had a positive Babinski, his toes would curl up. For the pulse, we're going to go behind the medial malleoli, and we'll feel for the pulse, 2+ pulse. And then we could do the same thing on the left extremity and verbalize we have a 2+ bilaterally. Okay, now that we've finished with the lower extremity, we'll go ahead and hand sanitize again. And we'll ask our SP if they could please stand up and walk straight. And come back. We'll go ahead and listen to the heart sounds. The mnemonic we want to use is apartment M225A. That stands for the aortic, so we'll check that aortic first in the second intercostal space on the right. And then we're going to go to the pulmonic side. Go to the tricuspid. And then we're going to go to the mitral. And if this was a female patient, a tip you could use is lift their breast up. Okay, we could make a comment that we heard a regular audible S1, S2, no murmurs, rubs, or gallops. Start off listening, we'll switch it over to the bell, and we'll use that to listen above the clavicle. And the instructions you want to give is, when you feel my stethoscope, please breathe in and breathe out.